This conference will now be recorded.
This is the March 7th high risk advanced recurrent prostate cancer group. Anything else I need to say? Okay, let the meeting be.
Yes, there is. I'm Ben Nathanson and I'm moderating this for the first time. Go ahead.
As if nobody could tell. Yes, I am Ben Nathanson and I am moderating this for the first time. Thank you all for your patience. It's nice to see you again, all of you. So we begin by talking to the new guys. And we have a standard set of questions that we ask. So I'll start with you, James Miller, was it?
Yes.
Okay, welcome. The first question is, we get personal right away. How old are you?
I'm 60. I'll be 61 in May.
And where do you live?
I live in Rialto, California. That's near San Bernardino, if anybody's familiar with the area.
How did you hear about us, James?
I heard about you guys today when I was on the Zero Support Lounge for advanced prostate cancer.
What year were you diagnosed?
2018.
Do you remember your Gleason score and PSA at that time?
Yes, my Gleason score was 7. 4 plus 3. And my initial PSA was 135.
So, which doctors have you seen and where did you see them?
Well, my initial diagnosis, I lived in the Bay Area. I lived in Richmond, California. And my first oncologist was Andrea Harstark. She was at Kaiser Permanente in Oakland. I heard today that she moved to San Francisco. But she was the first oncologist I dealt with. She was great. And well, when I was living in Richmond and I got the diagnosis, I was living alone. And all of my family is in on the West Coast is in Southern California.
Mm-hmm.
So a year after the diagnosis, I moved down here to Rialto. Because when you get news like that, you can't really deal with it alone.
That's right.
No matter how strong or tough a guy you are, that's hard to handle for anybody. So I figured, okay, I may not have too much time on this earth, so I might as well get together with my family and get to know them again.
Mm-hmm. Mm-hmm.
And it was better.
Yeah.
They've really helped me.
That's good.
That's beautiful, James.
Thank you.
What was your first treatment? Was it a prostatectomy, radiation, hormone therapy, chemo?
Well, I had a choice between chemo and ADT, and I was trying to move and untangle myself from my life in the Bay Area, so I chose ADT. And I've been on that ever since. You know, first it was elutamide. Am I saying that right? I got a shot of that, and then I got birotteron, prednisone and Lupron shots every 3 months. And it's been 4 years. I've been on that ever since. My PSA level now is 0.1, and it's held steady for the past 3 or 4 years. So everything's stable now.
That's good.
Are any of you familiar with Kaiser Permanente?
Yes,
Yeah.
I am. I was a Kaiser patient, but I was fortunate enough to have a crossover with UCSF. In fact, that's how I got to meet Andrea originally, because when I was diagnosed in 2007, James, there was a contract with UCSF. They hadn't opened the new radiation center in South San Francisco. So they gave me the choice of going to UCSF, and the rest is history. That's why we're here today.
Yeah. She told me that she taught there.
She did.
First.
She did.
And she moved over to Kaiser in Oakland.
She did.
Yeah.
I'm the person that told you today that I also have her as my oncologist.
Yeah.
That's right. That's right, Jeff.
And not only that, she, one of the things that was great about Andrea, I think she moved across around 2013 or 14. She was so committed to making it easier for men on hormone therapy, and she actually tried to start a program to deliver specific assistance. She tried to start a clinic to deliver specific assistance for men on hormone therapy, which is where we came together, because I was also advocating for the same thing at the time. And so that's why I have a lot of respect for her. She's a lovely person and a great doc, a great GU med doc.
Yeah, I spoke to her before I left the area, and she gave me a list of doctors, the oncologists, to check out. One of the names was Dr. Joseph Chan. He's in Fontana. So I've been going to him, and he's been doing good so far. And everything's been steady.
We often counsel people at Kaiser wherever they are in the whole of the country, including Virginia and Washington and wherever they are, that they can seek a consult with Dr. Hartstock as well. So you can always get a second opinion from her, James, if there's things you're concerned about. I would say that there might be additional steps that some of the guys have taken in this group that you have not done yet, and we can talk to you about that briefly.
Okay.
At the same time, the fact that you have, you're still doing fine on abiraterone. We have mixed feelings about that, because we've seen some people stay too long on abiraterone, and then it's hard to treat them later. That's what Dennis Correa was saying to you earlier on in the Zero meeting. And we'll let these guys talk about it, and you have to be very proactive at Kaiser. But certain things that the guys may raise with you is, for example, treating the primary. You've never had your primary, your prostate gland treated, either by surgery or by radiation. And a bunch of the guys here with metastatic disease have asked for that, and because we seem to think it makes a difference now. That wasn't the case many years ago. That wasn't the case probably even 5 years ago. But today, people like Herb and Ken Anderson and others have actually had their prostate gland treated later in the treatment process. Where is your metastasis right now?
Well, it was in the spine, the rib cage, the pelvis, the thigh bones, and a few spots on top of the head. I just had my bone scan and my CT scan last month, a few weeks ago. And there weren't any cancer cells there in those areas anymore. So I don't know.
Well, again, you've got to give it some thought. I'm going to turn it back to Ben, but I think the discussions are, one, treating the prostate, and two, maybe you want to get off the hormone therapy for a little while and see how you do. And that's a good discussion to have with Andrea, with Dr. Hartstock. But Ben, I think that might be where we throw this open to the audience. Oh, one, go ahead, Ben, because I know you haven't finished all your questions.
I can't hear you, Ben.
We can't hear you, Ben. But you're not muted.
I bet you can hear me now. So
Yeah.
did you get, thank goodness. Did you get genetic testing, James?
Yes, I did.
What
And-
kind? What did it show?
BB, whatever, 2. It said it was
BRCA2.
BRCA 2,
Mm.
I think. That's what I remember. I have the whole thing in my files. And apparently it was undeterminate. At least that's how it read. So, but I've been going through my family tree. I've been going through my ancestry, and 4 people that I know about that had prostate cancer at some point. 4 of my ancestors. So it is I think in my opinion, it is genetic.
So there, as you may know, there are 2 kinds of genetic tests. One is this hereditary test, a germline test, and the other is a test of the tumor itself. You
Mhm.
had just the germline test, the hereditary test.
Germline test.
The reason there are 2 is that the cancer itself mutates on its own. It's not an inherited or an inheritable change, but the cancer can become quite a different animal as time goes on.
Okay.
But you just had a blood test for your inherited, for your germline
Yeah.
genetics. Okay.
Which, by the way, if you have germline BRCA2, in a certain sense, that it's good news, in that there are more drugs available for you to use moving forward. It's bad news in the sense that you're more likely to be exposed to other cancers, which I hope Kaiser has talked to you about.
They mentioned that it will progress.
It's more than just progression. If you have what's called BRCA2 germline, or you've inherited the BRCA2, meaning you got it from one of your parents, then you have a higher risk for cancers other than prostate cancer. So, for example, melanoma, pancreatic cancer, male breast cancer. You should be you should be checking every year. You should be getting a mammogram every year. If you have prostate cancer and you carry BRCA2, then you should be talking to your doc about checking on these other cancers. Anybody want to add to that on that subject?
Rich, it's John. James, when you were trying to remember the name of your mutation, I wasn't 100% sure you said BRCA2, did you?
Yeah, it took me a while to remember it because I don't look at that often. I just know that it was done, and I have the file. So it took me a minute to come up with it. So
But that's it, right?
yeah.
That's it. Okay.
Do any of the women in your family have breast cancer? That's also caused by BRCA2.
Well, my maternal grandmother, she died of cancer, and I think it was lung cancer, but it may have been breast cancer also.
There's BRCA2. Frequently, the women also get it. I had an aunt and her daughter that both died of breast cancer.
Yeah, that sounds right.
The doctor didn't say anything about it. It hasn't informed his treatment, so it's not clear that we should seize on this thing as an actual fact.
Yeah, I think my concern there, Ben, and I do agree with you, is that if in fact James does carry the BRCA2 mutation germline and he needs to check that, then we would encourage him to talk to his doctor about checking on various other cancers that he may not be doing right now. So James, what we're saying is we don't know for sure, but part of your homework before next week is to see if in fact you have an inherited BRCA mutation. And if you do have an inherited BRCA mutation, we'd strongly urge you to talk about other precautionary tests you should be taking with respect to risk from other cancers.
Yeah, I'm definitely going to push for a PSMA test.
What's your current PSA, James? James, what's your current PSA? What's your current PSA?
0.1.
So it's very unlikely that a PSMA PET scan is going to show much.
Okay.
Because they need a certain level of tumor to detect it.
Oh.
Isn't 0.7 what has been recommended by Rick and others?
Yeah, but his is 0.1.
Correct, which means he'd have to get off ADT to have run that test. The thing is that the state he's in, most of us would be quite happy to just keep going along with the same treatment they've got until the PSA starts rising.
Yeah, I have a fear. Again, this is my fear. This isn't medical advice, but it's my fear. I've just seen too many guys who spend a long time on that first, second line anti-androgen, whether it's enzalutamide or apalutamide or darolutamide or abiraterone. And then when they come off of it, we can't find the best thing to treat them with. And I'm not going to name names, but you guys know some of the people that we've seen that with, and Len certainly does. And so there's another and there's no evidence. Well, I shouldn't say there's no evidence. There is evidence that long-term treatment on these diseases does mutate the cancer. So, when you've been on it that long and you're doing well, maybe you do what Dennis Correa just did, and in conjunction with your doctor, you decide you're going to take a break for a year, and then you go back on it, because it keeps the cancer off guard. I don't know. I mean, I defer to Len and to Herb and to Ken Anderson, but it is a real concern to me, and it's anecdotal based on where we've seen men do so well. Rob, God bless him, Rob Boniscus. There's another situation. Jake, and these guys got 3-4 years out of that first one. Len?
After Abby stops working, don't people have more metastasis and then they have chemo at that point? It's not that there's nothing. I mean, you have PARP inhibitors if you've got BRCA2, but don't you go to chemo normally?
No,
Is there some reason you can't?
Yes, there's other things. So I think it's not so much Abby stopping working, it's whether the cancer is considered to be hormone sensitive or castration resistant. And then the approaches are different. So different therapies become imperative or available once you become castration resistant, which means that the hormone therapies stop working. So chemo being one of them. It's not to say it isn't an option, but there are several others. So for example,
Rick was saying there was nowhere to go after Abby.
No,
so I was wondering.
It's not exactly nowhere to go. I mean, I came off Abby. I am now castration resistant, and now I've already had Provenge, right? Which is,
Yep.
And then I will be taking lutetium. So there's lots of stuff to come.
Yeah.
After that, but the question Rick brings up is that like just with me and with others, and I think it's the same with Steve Saft. If you're on this drug, the receptor wants to do what it can to get out from under it. And that means that mutations become more possible. And then once you get this mutation, then it becomes harder to treat.
So can I just qualify what I said, because I was using shorthand, I suppose. It's not that there aren't other treatments, Jeff. There are, but none of those treatments seem to work for any decent period of time. You work through one treatment, you work through the chemo, and it's okay, but it may not work, and then you try another thing, and then you try another thing, but you can't get a durable response from a drug. And this was first really observed around 2014 or 2015. It came out of the Dream Team, which is a Stand Up to Cancer initiative. And Eric Small and Rahul Agarwal at UCSF made the observation. I was actually in the audience the first time they made it, and it's now well recorded. There's research and papers on it and what have you. That the cancer mutates. Now, they didn't tie this into long-term use of a particular treatment, but what they did say is that, when you become castrate resistant, you can find that your drug has changed, and it starts to look more like small cell neuroendocrine. What we've noticed anecdotally, and I stress that anecdotally, and it's not medical advice, it's just what we've seen. We've seen these guys who get really good responses initially from these drugs in 3 years, 4 years, that we can't, when the PSA starts to rise, we can't find something that really, really works for them. And so maybe a strategy to discuss with your doc is, well, let me take a rest for a while and then I'll go back on it, because it didn't stop working. It didn't stop working. And even for some people, for Steve Saft, we just saw he failed abiraterone years ago. Now he may be getting a response from it right now. So and this is an interesting discussion to have with all your doctors. What is the value of keeping your cancer off guard? In other words, deliberately switching and chopping your treatments so that the cancer never settles down and finds a way to skirt around it. So that's what I'm saying, Jeff. It isn't that nothing works. Things work, but they don't work. They don't have legs. Now,
Thank you for this. This is I'm sure everybody appreciates, or a lot of people appreciate your comments about this.
Well, actually, Dr. O is a person who believes what you said, Rick. He has a protocol, he mixes it up. He'll put people 3 months on this, then move them 3 months on that, so that they never develop resistance to any one thing.
This is John.
Can we go to Len first and then go ahead, Len?
Yeah, so I did have to step away for a moment, but if I understood the following James Miller's story, if he's BRCA positive, so he has an alternative effective therapy in the form of the PARP inhibitors, would be a great rationale for stopping the abiraterone, taking a break from that and switch to the PARP inhibitors. But I'd be interested in hearing from Richard Wassersug, who wrote the book on hormone therapy.
That's just what I was going to say. There's a table in that book of people who should stay on hormone therapy for life, and most of us are on that table. And I would really be dying to know what Richard has to say about all this now. A couple of years have gone by, and
all right. Well,
I'm glad you're here today.
Len, thank you. I'm flattered. The game is changing rapidly for all of us. The earlier use of chemo is an example. There's a discussion within the clinical trials of not only combined therapies. I mean, now you don't go on chemo without being on androgen deprivation therapy. And they're now talking about triple therapy, going on an ARAT, androgen receptor targeted agent, like one of the darolutamide, enzalutamide, apalutamide drugs, or plus ADT plus chemo. So to James there, you've got a lot of options. And I think the idea of saying, if I were to go off abiraterone, what would be my other options? And the clear one, as Len said, would be the PARP inhibitor, as to take a run at them. Now, they're not without side effects. They're not easy drugs necessarily to take. But I think you have a lot of options. Whereas I was surprised when you said, oh, I want to get a PSMA test. And I was thinking, I didn't say it at the time, well, what are you looking for? You already know you've got a lot of bone mets. They can't necessarily target that many with cyber. You've got more than what we'd call oligomets. So you are going to be in the realm of systemic therapies. And lutetium really isn't standardized yet. We don't know the doses right. Right now, you have a case for going off abiraterone. What is that? Thank you.
Excuse me.
You have a case for going off asking about going off abiraterone. You have a case for exploring possibly early chemo. You have a case for exploring PARP inhibitors. All of these sound very reasonable to me, and I'm staying with that. With I think is the general sort of views that have been presented here. You should be exploring other options. PSMA is wonderful from a theranostic, from both diagnostic and therapeutic perspective, in principle, but you're not there. I mean, you're not like Herb here, so heading for Lu177 yet. I mean, you're not in that realm. That isn't as well established as the PARP inhibitors are at this point. So there you go. I see you smiling, so that's good. That's what on my screen. You realize you have options, and I think that's what we're trying to encourage here, people to view it that way.
Now,
can I answer the question?
Yeah.
James, are you still working, or do you still work?
No. I went on SSDI, Social Security Disability.
Okay. Are you wedded to? Do you feel like you've got to keep that insurance forever? I mean, Andrea's a great doctor, but if your disease progresses, you might want to, at the end of the year, think about switching and getting more professional care at UCLA or a big place down in Southern California. It's just a thought. I don't know how many people will get great care with the kind of insurance you have right now.
Yeah, so I was going to comment on that too, James. Have you opted yet for? Are you on Medicare yet, or are you still in the waiting period?
Well, I have Medicare now. I just got it a few months ago. So
it may be more difficult for you to do. I don't know, but where you are, I'd be going to see Tanya Dorf at City of Hope in Duarte.
yeah,
It's around the corner from you.
yeah, I went to get a second opinion at City of Hope. And they're the ones that told me to go ahead and go on ADT.
Which was when? How long ago?
That was 2018.
Yeah, so but well, I guess what we're saying is that now, 4 years later, you need to make a change, and you've got to fight so hard to get any sort of treatment at Kaiser. And the reason Kaiser isn't chopping and changing you is because it's too easy for them to leave you on the abiraterone. And if you were somewhere else, they might chop and change you. And if you can switch, and I think you may be able to, because you've always been in an Advantage plan, and you may be able to switch out of that Advantage plan, but I'm not certain, then I would be looking to move your care to City of Hope and to Tanya Dorf. Because she's really good. And City of Hope's close to you in Rialto.
Yeah. Well, I found out that the kind of coverage I have now is only for my county, San Bernardino County. I don't know if they would let me go to LA County.
Well, first of all, I thought, is Duarte in LA County, or is it Duarte in San Bernardino County? I mean,
it's LA County.
It's LA County. The point is that you cannot, in your Advantage plan, you can't get there. I don't think.
No.
Well, I shouldn't say that. I think you can, but you're gonna have to run it all the way up the flagpole and say there's no GU Medocs in Southern California. There's nobody who is specifically a genitourinary medical oncologist. I want to go outside, but it's going to be a heck of a fight. What you've really got to do is to get into a different Medicare plan that will allow you to go anywhere and see any doc. And those plans are available. Now, is it going to be more expensive than the Advantage plan? Probably is. How much more? Maybe a couple of $100 a month. Are you going to get something out of it? You're going to get a huge amount out of it because your care is not state of the art right now. You know, we haven't talked about treating the primary. It's another thing that really people are doing today. And Kaiser's not saying to you, I mean, you know, you go back to Chen and you say, well, doc, I was in this meeting. All these guys had metastatic cancer and they've all had their primary, the prostate gland radiated because we think there's a benefit from that right now. See, what's he going to say to that? He knows, but they don't suggest it for you.
Okay, that's a good question. Yeah.
So if they don't let you change now, open season is usually around
And you're
December.
unplugged.
So, yeah, we may have to, Rick, he hasn't gotten the pushback yet. It may be premature to talk about this, and as Peter says, it's not open season yet for switching.
Right.
So this may be something to take on, you know, in the future. For
Correct.
now, James, are you clear on what you need to do? You have a to-do list?
Yeah, there's a lot I want to talk to Dr. Chan about.
That sounds good.
Hey, James. Hey, Ben. This is John Birch. I would just interject. If James is in his first year of Medicare, I think you have the option, without showing insurability, to convert from a Medicare Advantage plan to a supplemental plan. And that's the kind of plan that I believe Rick is describing, that gives you portability anywhere in the country and not tied to a particular network. You know, the issue is, does the doctor take Medicare? But with the Advantage plans, you have to have, it's a specific network you're tied to. It's not as broad reaching geographically. So James, that's something you need to understand and look at. Don't wait until open enrollment in the fall, you know, because you just need to understand what your options are in advance of that.
That's a good point, John. Thank you.
Excuse me, Carlos, can I jump in here just for a moment?
Sure.
I'm also went through the same process myself. Was on disability about a year and a half later, converted to Medicare. That is, if you stay on traditional Medicare, there is less than $200 copay that comes out pretty quickly, and then they take other funds out of the actual Social Security check. So unless you're counting on all of that check for your expenses, that's how that gets paid. It automatically gets paid for you. But it opens up a whole lot of doors, and it opens up the ability to get scans that other health plans balk at and give you a real hard time getting, such as PET scans. Like someone just said, just make sure that people you're talking to take Medicare. Because if they don't, then they can bill you as a non-participating person, which is not going to get covered by anything except your wallet. Hope that makes sense. Give Social Security a call. I do believe you can still change to traditional in this period of time.
Okay.
Okay, thank you, Carlos. I'd like to, since it's 8:52, we probably should get to Mark Valens. Mark, so you've heard the shakedown questions. The first of which is, how old are you?
I'm 73.
And where do you live?
We have a home in Ashland, Oregon, and also we have a ranch that I've had for 50 years east of the mountains in Klamath County, Oregon, which totally burned up in the bootleg fire last summer. So I'm spending more time in Ashland now because the house over there burned up.
I'm sorry to hear that.
Yeah, we're sorry to hear that. Yeah.
How did you hear about AnCan?
At the Zero cancer meeting a few hours ago.
What year were you diagnosed, Mark?
3 years ago this month. And I had I'm a little bit of an unusual case. I had in January 2019, I had a PSA test and it was 1.7. And then at the end of January, I was camping at a very remote site down in Baja, California, and I couldn't pee. And had an excruciating 6 hours to get to an emergency room and get a catheter put in. And then came back up to the urologist here, and he checked my PSA, and it was 1.7. And so he went ahead and did a TERP, transurethral resection of the prostate. And when he did that, he did a biopsy, and it was Gleason 9. And then I got put on Lupron pretty quick. And then we immediately started looking for doctors. We went down to UCSF and talked to a number of doctors down there. And we went up to University of Washington, and there were excellent doctors both places. But we ended up choosing UCSF. But nobody wanted to do either radiation or surgery until I healed from the TERP procedure. So they wanted me to stay on Lupron for 6 months. And then the doctors down at UCSF got in an argument of whether surgery was better or radiation. And they had one of their tumor board meetings, and Mac Roach won out, and radiation is what I went for. Ben,
how are you doing? How are you doing? Mac was my doc, by the way. I know him well. How are you doing? Well, first of all, what type of radiation did Mac give you, and how are you doing now?
He likes hitting you with that super machine for 2 days, the cyberknife first, and then I had 6 weeks of daily radiation.
Well, you see, in my day, I sound like a real old fart here. We didn't have that SBRT option, so I got seeds and the radiation, and I actually got my seeds at Kaiser. But Mac was running the whole show for me, and he did well by me. I have a durable remission, so I'm forever grateful to Dr. Roach.
Because of my TERP surgery, the seeds wouldn't have worked, because the TERP procedure is basically a roto-rooter, and there just wasn't a solid enough place to put the brachy seeds.
Yeah. You're better off. I mean, if I had my time again, I'd do SBRT and pelvic girdle IMRT rather than the seeds. But so, it turned out well. How long did Mac want to leave you on hormone therapy?
He says probably forever. And I just talked to him again the other day. I bring it up every time. So my since the surgery, since the radiation, and I'm on both Lupron and Extiga, every 3 months my PSA comes back less than 0.01. And so he says, unless that budges, he wants to keep me on it. I'm a little bit worried since I had almost no PSA before it was diagnosed. If we wait until PSA comes on now, is it going to be pretty far along? I don't know. But so I'm just, as people have been saying, I had a medical oncologist here who's really good. Oh, she's one of the best doctors I've ever had, but she covers a lot of different cancers. So Mac is not referring me to a medical oncologist who specializes in prostate cancer. I haven't had a meeting with her yet.
He's sending you to Halaborno?
Yes, I think, is that a woman that?
Yeah.
Yeah.
Yeah, she's great. Yeah, it's a good referral.
Okay.
She's very good.
Because this morning I also got a recommendation for Friedlander.
Yeah, I like Terry very much. You can't go wrong with either. Both of them are very compassionate. Both of them are smart. Terry Friedlander is really more of a bladder cancer than a prostate cancer GU med on. But Terry knows me. You can mention my name. Halaborno doesn't really know us. She sort of knows us a little bit. What I like about her and Terry is neither of them want to will want to keep you on hormone therapy if you don't have to be there. I think the key thing for you to appreciate, and I don't know if Max explained this to you, but I would definitely dig down with him, is that if you're a 4+5 with very low PSA, it's not, it's a difficult treatment path, because we already know that something is very unusual about your cancer. And we've got men in this group tonight who had high Gleason scores and low PSA treatments. And, you know, that they're with us and they're doing okay, but it's not been easy for them because it's not the typical way to go. And I can see Max saying, hey, if it ain't broke, don't fix it. I can hear him saying it. If it ain't broke, don't fix it. I will tell you, Matt kept me on for 28 months, and I'm glad he did. I had no observable metastasis, although it was out the capsule. I'm assuming that you have no metastasis. Is that right? That they've seen.
Small ones. I've got one on my spine and then into the seminal vesicles.
Well, you know, it's a tough one, and I'm really pleased that he's moving you on to either Alaborno or Terry Friedlander. They're both great choices, and I think you've got to have a heart-to-heart with them as to, you know, what they think. Have you had any genetic testing? Have you had any somatic testing?
I had the germline testing, and I'm okay. There's no problem there.
Yeah, I think if it were me, I'd be asking for a somatic test to see if there's anything unusual, because this is an unusual cancer, and I bet they're going to see some mutations, whether they'll be actionable or not. But at UCSF, that's fine because they're doing so much research, they may something. But I think I'd be saying to Mac, hey, can I get I want to run, you're covered. I'd like to get a somatic test. And at this point, you could do it with blood.
Okay.
I mean, you could get a liquid sample, send off to Foundation Medicine or Caris, or we like Foundation Medicine, but they're not the only ones that are out there, or Guardant. But I definitely would get that, and I would get it even before you see Terry or Halaborno, because I think it'll inform them.
Okay.
So even with the low PSA, he can get a liquid biopsy?
The problem is that this low PSA.
Oh, right. It's not indicative. Right. I understand.
It may not be indicative. You may not get a result because your PSA is low, but I think you got to talk that out with Matt or with one of the GU med-oncs. But I think if there's any way that they could see a somatic test, you may not get a result. But
yeah, there's obviously something going on.
Steve Saft, when they did that very first FMI analysis for you, it was on a tissue sample, right?
Yes.
May I ask a question here to Mark? This is Richard Wassersug here.
Absolutely.
On the side. Mark, I'm just with the bone scan showing 2 localized mets. I assume that they're asymptomatic at this point. Was there any discussion about treating them with something like cyber knife to go after the particular, when you have what we call oligomet situation, low met presentation? Whereas there's been discussion about what we call debulking the primary, going back and treating the tumors that might be in the gland. The case can also be simply made to treat a localized mets when there are limited numbers and they can't be treated. What's the discussion on that?
I wasn't clear. The ones it's a gland on the back of the spine. It's not the spine itself that it is spread to, and the seminal vesicles.
Okay, all right.
Must be a
Well,
lymph
it's-
node.
Mark,
it is-
did the TERP solve your urinary problems? Are you clear now?
Well, I don't panic about not being able to pee, but I'm up every 2 hours all night long, every night to pee.
Was there anything unusual in your pathology? Did it say something like ductal or small cell?
No, it's not small cell, and it was just the 5+4.
And it didn't say ductal. Had no
No,
carcinoma.
I asked about that, and they said it was not.
Or intraductal for that matter.
I hadn't heard that.
Okay,
But
thank you. So you clear on what to do next?
well, it sounds like I'll get a somatic test because
Yeah.
I'm just waiting to, I just talked to Mac this week, and so he was setting me up to see the medical oncologist down there. But so that's, and now you guys have thrown this thing. Mac has just always told me to stay on the Lupron forever, and you guys are giving me good reasons to question that. So I've got something new to work with.
Yeah, that sounds good. And certainly Rick's suggestion to do it before you see the oncologist is a great idea. Do you have any more questions for us?
No, I have the issues that probably everybody does who's on Lupron. A lot of fatigue, brain fog. I sleep a lot. I take a lot of naps, and it's starting to get to me. I mean, I did pretty well for a long time, but now I'm gotta find a therapist or something because I'm having trouble dealing with it after so many years of having no energy.
Well, it's probably not something we could go into now, but certainly you've come to the right place. We have a lot of experience with that.
Well, great, and I'm glad I discovered you guys.
We're glad you're here.
Hi, Carlos Huerta. Can I ask a question, please?
Sure.
Mark, I didn't quite hear. How long ago was that QUR done?
What?
How long ago was your TERP done?
3 years ago this month.
Okay, I didn't know if tissue was still available for that, but it probably sounds like that may not be.
They keep the tissues. There's always some left.
Yeah, there always is. I just don't know how. Well, you'd have to ask, the receivers. The 3 different people mentioned if that makes a difference for them or not. I did have my lab looked at about 2.5 years after it had been done. You're right, they do say that quite a while. The second question is that I just want to throw out, you may be in a position that I am, which is I'm a low producer. And although my numbers have never really gone higher than 1.5, when I did have my recurrence, I had multiple meds, probably 17 different sites. And we're seeing if we can get it back under control with Lupron as well as Rebecca. That's just going to tell us over time. I was quite surprised that when I waited for my PSA to rise to over 0.7, how many meds were showing up at that point. I think everybody was. So I'm not sure where in your situation, where I would draw the line as to whether you should or should not pursue that. PSMA scan, it's just be where you are. It's nothing else for baseline.
Okay.
So whoever came up with that idea of using the TERP tissue, brilliant. Sorry, my landlord just arrived to put in a new thermostat. I had no heat this morning today, so I just had to go run and let him in. But that's a brilliant idea, because the likelihood is that your disease hasn't necessarily morphed. Whatever it was when it was with that low PSA, it probably had those mutations even back then. So, you know, usually we say, well, try and get something new, up to date, because it's moved as a result of tissue, but it probably hasn't. I mean, Steve Saft is looking at mutations today that we saw 3 or 4 years ago when he was first diagnosed. So I think there's really good reason to do that and get that tissue sample off to Foundation Medicine and see what's there.
Okay.
And we'll put
Mark,
you in the we'll put you in the database, and you'll be getting reminders from us before every meeting, Mark. Same, James is already in the database.
Great.
Mark, I don't know if you know, we have a chat line that you might want to look at that, and I sent you a note there.
Yes, I'm just reading that. Thank you.
Great. Okay, you're welcome.
So I think we've covered the new people. And
Can I ask one more question?
yeah,
Like I told you before, my last scans, the cancer cells, the bone mets, seem to have gone away. Is that a usual thing, or is that unusual? At least that's what I got from my oncologist.
No, some people respond really well, and it's fantastic that you have responded that well. It's we don't see it as often as we'd like to see it. I mean, that's my response. What about the other moderators and Dr. Wassersug? I mean, what would you say?
I'll start off. I mean, that's why we have ADT. So that's why Charles Huggins got the Nobel Prize for discovering that he could relieve metastatic disease, not necessarily cure it, with ADT. The way you worded it, that the cells had disappeared, you can't really say, because the imaging is not at the level of the cells. The imaging is at the level of the tumor. So the tumors are no longer visible because they have shrunk into such a small amount. And some of them may have truly disappeared, but we can't actually speak at the cellular level. But it's a good sign, it's a positive sign, and it would be the case that the doctor might argue with you why you should hold the course. It's working. I mean, that's the alternative side.
I'm just trying to learn, that's all.
Rick, you were asking me a question as my power and internet went off. This is Steve Saft.
Yeah, no, I think we
late.
answered it. I think we answered it. Yeah.
Okay, sorry about that.
Don't worry. We just, you know, we've been talking to a man who has a very aggressive Gleason score and very low PSA, like you, like Carlos, like some of the other guys who are here. But Len and Ben and Herb, I mean, what would you say about seeing such a great response from your? See, it's so interesting because James is kind of the other end of the scale. He was a 4+3, but he had 135 PSA, right? So this is a man who is very responsive to, we would expect him to be pretty responsive to hormone therapy, and he was. And he was.
I mean, I agree, Rick. I mean, this is, oh, Len, go ahead.
I was just going to say, I think James' question was, is it unusual for his bone mets to disappear, at least by the scans? Was that what you asked, James?
Yes.
Yeah. So I don't know if it's unusual, but it does happen. Fortunately, it's happened to me. I had several bone mets. I was on hormone therapy, and I became undetectable. Now, sadly, it doesn't mean I'm cured. The current thinking is that once you have metastases to the bone, that you're not curable. They can treat you, but you can't be cured. You know, we try and hang in there, fight this as a chronic disease, and hope that they have a new advance in therapy that will change that law. But yes, bone mets can disappear and then they can reappear again as time. So I'm just trying to be real with you.
Okay. That makes sense.
That was a good question. I'm glad you doubled back to ask that. Jerry
Thank
Dean?
you.
Jerry Dean's in the house. Jerry?
Jerry Deans is in the house.
You're next. Please talk to us.
Yay. Well, Rick, maybe I ought to ask you to, I don't know where to start summing this group up, but I am on lutetium-177. I've had 2 treatments of it. We discovered brain cancer, prostate brain cancer in the brain back in late October, and validated that with a PSMA PET scan down at Duke. 32,000 images they took. Called me on the way home and said, you've got prostate cancer in the brain, and I had already figured that out and started the SBRT treatment, which we hoped would take care of a 7 millimeter, I think it was 7 millimeter brain lesion, left part of my brain. At any rate, we really thought that might be taken care of with the radiation, but in February we re-imaged the brain and found out that while things had gotten better in other respects from the lutetium-177, it had not touched the brain lesion, or at least we didn't think it did. And so now I'm scheduled for surgery of the brain, not next Wednesday, but Wednesday after next. And they can't do that with radiation anymore. So it's got to be done with surgery. That's the next big kick. The wonderful thing is, thanks to all of the help that Rick gave and Jim Strait gave and all of the people of this group, you know, the people up in Chicago have not kicked me out of the study. They've said, go get the brain cancer, go get the brain lesion treated, and then check back in with us in a few weeks and see if we can get you back in the study. And that delights me because the second treatment I had on lutetium-177, I had about 40-some% of my cancer in the lower hip on the left-hand side, between the well, it was a lot. There was a lot of pain there. There was a lot of pain there when I went into the second treatment up in Chicago, but they treated me, and one day later the pain disappeared from my lower back, and it hadn't come back since then. So I have very good reason to think that the lutetium-177 is impacting a lot of my active brain lesions. Not brain lesions, but bone lesions. Okay, so I'm thankful they're keeping me in the study. I'm thankful that I'll have another crack at that, and I'm staying in touch with Duke because I kind of consider them my home team, Dan George, and he seems to be very, very creative, and he says, keep getting treated at Chicago. If they kick you out of that study, come on back down. We'll take another crack from here. And apparently the lutetium-177 is not as far away as it once was. At least the last communication I had with Dan George was, it's coming. It's very close at Duke. So I guess there's even the potential for, moving from Chicago to Duke if it were to open up and if I were to be eligible. So I'm glad to be alive. I'm thankful for this group. You guys that are new here tonight, you're in the right place at the right time.
So Jerry, who's
Yeah.
doing the surgery?
There's a local neurosurgeon here in town that I have checked out and supposed to be one of the best. And he's been referred to me by the people that have treated me with the stereotactic radiation. So they say, you don't have an option for radiation anymore. We can't radiate it enough. But you got a good doctor. You got one of the best in the area. So I'm okay with that.
I mean, because this is tricky surgery.
Yes, it is.
And what is it, again, it might pay to talk to a specialist who does only cancer neurosurgery.
I think I'm too far down the road on that one right now.
Okay.
And I appreciate the question, but I went back to the radiation oncologist and she said you couldn't do better than this guy in the area.
Okay.
And so
do we know where in your brain it is?
Yeah, it's I've had some problems with cognition and ability to think. Sometimes I can remember things, sometimes I can't. I'm probably at the top of my game tonight rather than at the bottom. I think it's in the left lower.
I would have said left side, right?
Yeah, because it's, I can get to the point where I can't even read an email. I can't understand what people are saying to me. And they can put me on dextromethasone and in a few days I clear up. But 3 weeks ago, I couldn't have had this conversation with you. It was just wasn't possible. And I know the Dex is not a long-term solution. So, I start tapering on that next Wednesday a little. And I know it's tricky. I know this is not a slam dunk.
So, Jerry, I just want to say, first of all, you're doing way better than the last time I spoke to you, and it's a thrill. And I think Jim's on the call too.
Yeah.
As soon as I saw you, I texted Jim and said, "Get your ass on this call because Jerry's on." And so we're both with you. I can see you're doing better. I can hear you're doing better, and we're delighted. Secondly, I just want to say this is Herb's area. He runs a lab for brain injuries at the NIH. So, he's a really good resource when it comes to this type of situation where you need something treated. But those are the two things that I want to say.
Yeah. When the decision was made to go with this doctor, I just had to do the best I could to pick the best I could get. And
if it's a localized lesion, then you have a good shot if you can remove it.
Yeah. Yeah, he said there's an 80 to 90% success rate, and I know how that measures in brain cancer. So,
this is not brain cancer.
Yeah.
So this is prostate cancer in the brain. Brain cancer is much worse, Jerry. Because brain cancer is much more evasive.
He's been amazing, and he's been through some very difficult and strange treatments along the way.
But I think this is good. Certainly, you look great, and we're all happy they're here.
Yeah,
happy to be here. I can't tell you how glad I am to see you and hear you and hear you doing really so well in terms of your cognition and everything. I love you, brother.
Yeah, man, I love you too. And the cognition is temporary. I want everybody to know that, because that can be here today and gone tomorrow.
Well, we're just glad we're with you today and not tomorrow, then.
That's it from me, Ben.
Thank you so much, Jerry. It's so good to hear. We're all delighted to see you. Jerry Pelfrey.
And Jerry, if you want to reach out to Herb, I'm writing it down. I'll make the connection right after the meeting. It's herb@ancan.org, but I'll connect you right after the meeting.
Okay, great.
Yeah, Herb puts the brains in the brain trust.
I got a non-medical comment for Jerry. Jerry, your attitude is impressive, man.
Pardon?
Your attitude is impressive.
Yeah, well, I'm longer on attitude than anything else sometimes, so
don't shorten it. Man.
Yeah.
Oh man, you're an inspiration, Jerry.
Totally.
Well, I was diagnosed in '99, so this is how I fight my battles.
You should also know, guys, that Jerry was the vice chairman of us too. And then the disease got the better of him and he had to step down and allowed Mr. Schreit to become chairman. But Jerry has been working on behalf of us prostate cancer folks for years and years and years. And he is a wonderful, incredible, fine individual.
Thank you, Rick.
So, Jerry Pelfrey, you were on the call first, and you wanted to take some time.
Yeah, I just really have a question I'd like to throw out to everyone. Excuse me. Because right now I'm dealing with really a lot of depression and anxiety. And I didn't have that before, but what happened was my palliative care doctor decided that he didn't like me to have two drugs, two opiates, he says. I'm taking venlafaxine, 2 venlafaxine in the morning, and I was taking 2.5 milligrams of Xanax at night, and he didn't like that. So he tried several things, and it's screwing me up. And I was just wondering what the rest of you gentlemen are doing for depression or for anxiety.
Well, I'll jump in here. I'll jump in here, Jerry, because I'm on. I've been on venlafaxine for many years, and when I was put on hormone therapy, I finished up doubling my dose of venlafaxine, and it helped me a great deal. And I cut it back when I was one of the lucky ones that was able to get off hormone therapy. One thing I would ask you to speak to your docs about is, rather than taking, maybe you're doing this, but rather than taking 2 in the morning, to use extended release. Are you using extended release venlafaxine, or are you using the pills?
No, it's extended release, but that's the first thing he did was he said, well, let's have you take 2 venlafaxine in the morning and 2 at night. And that didn't work at all.
Okay.
So,
okay.
You know, that's what he tried.
So let me tell you something else. So the first drug they put me on didn't work for me at all. It was a Paxil or the other one, and then they switched me. And then the second one did work very well. So, and I've been on venlafaxine now for going on 20 years, and and it helps me a great deal. So don't be surprised if the venlafaxine doesn't work. Maybe you need to be on a different psychiatric medication. You know, I'm talking here, but really I've got to defer this over to Dr. John.
Why wouldn't you go back to the Xanax? If that was
sorry.
working.
Hold on a minute, Steve Saft. Let's give Dr. John, because we've got a professional on here who really knows what he's talking about.
What size are those venlafaxine capsules? How many milligrams?
Yeah, you would ask me that. It's not a high dose at all.
Well, I mean, if they're a very low dose, you know, it could just be that you're not taking enough. But if you're getting a good, robust dose of venlafaxine, but you still have a lot of depression and anxiety left, then Rich is right. You have to try something different.
What color are those pills? What color are the capsules?
White. They're white.
They're white. Okay. No, that doesn't help. Because I've got a peach one and a gray one, and that might have helped, but go ahead. Sorry, John.
So you see, there's at least 3 possibilities of what they are. Chances are that drug might have been picked for you in hopes. Do you have some pain also?
I did. Now that I've been working out aggressively, my pain really has gone away.
Oh, excellent.
And I thought that this exercising aggressively would help me with the depression and anxiety, but you know, I can't pronounce this, but it's something like olapletin. It's very similar to Xanax, and he put me on that. And even my wife noticed that I've been more depressed. So I know I've got to get off that. So
gee, I don't know what that is. It sounds like some Mexican drug. Maybe Carlos will know what it is.
No. It's a anti-seizure, depression. It's almost exactly Xanax. It just lasts a little longer than Xanax. I think they say something like 12 hours, where Xanax lasts only 6 or something. But
maybe something like clonazepam.
That's what it is. You just said it.
Clonazepam.
Is there something wrong? Yeah, is there something wrong with me just going back to that low 2.5 grams of Xanax at night? The problem was that I was using 2 opiates. And I understand opiates, and I hate taking pills. So I'm not really concerned about getting addicted to any of this. But is there any medical reason that I should not be doing that and do like maybe Rick said, try?
What your doctor is worried about is the development of tolerance and dependence. And the drug Xanax can cause tolerance, meaning that you'll gradually possibly need a higher dose to get the same effect, or dependence, meaning that if you go off it, you might suffer from some kind of withdrawal problems. I think that those particular drugs are really nice in the short run. Like for me, when I first got diagnosed and got real panicky and shaky, they put me on clonazepam for a few weeks, and it allowed me to sleep and stop shaking, and then I got rid of it. That's an appropriate way of using that drug. But for longer term, it would be better if the job could be done with a drug that doesn't cause tolerance and dependence. For example, venlafaxine or if that's at an adequate dose and not working sufficiently, a switch to a different antidepressant would be appropriate. But none of these are opiates.
Okay. So the idea of just increasing the venlafaxine may very well be the answer.
If you're only on a very small dose.
I looked up what a white venlafaxine is, and I don't know that they're all different, but it could be the 225 extended release.
Well, I think that's an adequate dose, and although some people will push that drug up to 300 or so, to me that is maybe a sign that venlafaxine's not going to cut it if you're already up to 225 milligrams.
No, twice. He's taking two. I think Jerry, didn't you say you're taking two of those?
That I'm not taking the high dose.
You're not.
Well, maybe you
so
maybe you are and don't know if they're 225s.
Yeah. Okay, I guess you kind of answered my question. I guess not a lot of us in this group have anxiety or depression. Or if you do,
we sure as hell do.
I'm pretty sure that's not true.
It's universal.
Oh, yeah.
It's just
but
that
you're not doing what I'm doing, evidently.
Well, we all cope in our own ways.
No, we are doing what you're doing. I mean, I was on a Xanax-like drug for a little while, like I said, and then got off of it. And I'm also on an ongoing dose of escitalopram, which is an antidepressant, which is helping me a lot.
So maybe I just have the wrong antidepressant. Maybe
it may be. Yeah, maybe.
So that's something to talk to my doc about.
I got a feeling it might have been picked in hopes that it would help your pain, but you could switch to something else and try it. If you want to, I'll put my email on the chat window and you can write to me, okay?
Okay, I'll cut out of here so that other people can ask questions. And what I'll do is I'll put in the chat the exact medication of the venlafaxine, how many milligrams I'm taking.
Right.
Yeah.
So I just want to say one thing.
That would be most helpful.
Can I say one thing?
Hold on 1 second, and then let me get in, and then you're after me. One thing you should know, Jerry, is that it's not as simple as stopping one drug and starting another when you switch these mood regulating drugs. You have to get off it. You have to wait a while before you can take a second one. Maybe John, do you just want to explain? Could you explain that to Jerry? I mean, it's not like the doctor can say, "Oh, we'll stop taking this one today and start that one tomorrow."
That's absolutely right. I'm glad you mentioned that.
Well,
your
you have to
palliative
paper. You have to titrate off these.
Yeah.
Yeah, I just want to say that what John was saying is about clonazepam is very important, because I've been on clonazepam for a number of years now and can't get off it. Physical dependence, and I'm taking it. It's no longer effective. I don't want to keep increasing the dosage, but if I don't take it, I'm up and panicky. So the idea that it's short-term use, and if you can get off it and change, I think you should really do that, because I'm stuck in I'm stuck in a cycle with that drug.
Yeah.
Thank you. That's good to know.
And like everybody else with anxiety and depression, it's totally common.
Yeah, it's all of us, I guess. Ben, I'm done. Thank you.
Okay, thanks, Jerry. Joe Blanchett, you are next.
Joel, we can't hear you.
Oh, you got the green
Okay,
mic,
I
but
bet you can hear me now.
yes.
Yeah, okay, good. I finished my a small update on myself. I finished my 5 treatments of SBRT to my left, my right occipital condyle bone exactly a month ago today. I'm taking a PSA tomorrow, so I'll know which way the PSA is headed, regardless if it heads up or down. And my 3rd PSMA PET is probably in the near future for me. So Dr. Antonarakis has asked me to have Dr. Eblin, my radiation oncologist, call him, and he will do so after I get my PSA test score, and so we'll go from there. But what I wanted to talk about is something I just found out today and yesterday about Johns Hopkins and Walter Reed. And I'm sure you guys have talked about it many times on this in this forum, but I not been present when that was discussed. But I found out that Johns Hopkins has a multidisciplinary clinic in MDC, and they've had it for years, where you get boarded by a urologist, a radiation oncologist, a medical oncologist, a pathologist, and a radiologist. You go for an interview in the morning. A nurse and a doctor talk to you to gather all your final facts other than what the records are showing. And then at noontime, at lunchtime, they presented before this board of 6 doctors. And in the afternoon, they recommend the next treatment in your prostate cancer journey. I think this is a very valuable service, even though I personally have not done it, but 2 people in my US2 prostate cancer support group have already done it. I found out Walter Reed does it on a Monday every week. So just for the guys in the area here, if you're a veteran, just so I just want to make sure that everybody knew that. As I said, I'm not probably the first to discuss this in this room.
So the question I have for you, because this came up in Len's meeting earlier on today. We've heard about it, but usually that's for an initial intake and not for advanced patients. Is this for people that have just gotten diagnosed, or is this and trying to determine where to go, or would this be somebody who has advanced disease, like say a Herb,
Yeah,
who wants to shift over?
Yeah, I think you're right, Rick. The impression I'm getting, it is for basically initial patients. I have a guy who was on active surveillance for 18 years, and he just went before the board at Johns Hopkins, and basically the surgeon that Antonarakis recommended was on the board, and he's going to have surgery in the next couple of months from that same surgeon, who was very popular. Another thing I found out, just another example, in Walter Reed, you had this guy with a Gleason 9, and he saw a Dr. Chestnut as Walter Reed, and the more he kept on talking, it was an initial phone call for me with him today, and there was a fight between the urologist and the medical oncologist, and the urologist won. So they scheduled his surgery, and the guy asked for a PSMA PET scan. That during the board, when they went before the board, the urologist won. So they scheduled the surgery, and when a day or so before surgery, the guy asked for a PSMA PET scan, which they gave him. But they found out then with the PSMA that not only did he have prostate cancer in his prostate, he had 15 lymph nodes all around his body with prostate cancer. So then he immediately switched him from surgery to radiation. So it just goes to show how important the PSMA PET is very important also for initial diagnosis.
So I think, Joel, it's not that, I mean, it's not that uncommon. I mean, when I came to NIH, I had the same situation that basically it went to a consult of all the different specialties and to decide what should be next.
Okay.
So, how's your PSA doing?
Well, I take a PSA tomorrow. My last PSA for my baseline before my radiation was 3.6. And so I'm hoping that for some reason, Dr. Eblin, the radiation oncologist, doesn't think it's going to go up. He thinks it's going to go down. There's not going to be a PSA flare like there was for my left iliac bone radiation. So we'll see what happens. I'm open to either way. Anton Arakis is interested, and so is the radiation oncologist to see which way it's headed. I think he gave me a head CT about 3-4 days ago. He was pleased with my brain was not swelling from the radiation. So I think he's looking positive towards a good outcome. But hearing Jerry Dean's tonight, my cancer is very close to my brain, so I hope it doesn't migrate up there.
Okay, we look forward to a good report from you.
All right, thank you.
That it for you?
Yes, that's it. Thank you.
Thanks. Call Foreman.
Good evening. I've already chatted earlier with Landon and with Richard Wassersug, so they know what I'm about to ask. So, but before I do that, just as a follow-up to last week's meeting, those of you who were not on the call, I did start my first round of chemotherapy that Rick has been pushing me for some time to try the chemo, and I'm on a combination of carboplatin and cabazitaxel. I am going to have my second round this Thursday, which will be 4 weeks since the last one. My results have been tremendous. The PSA has dropped almost 80% after just the first round alone, and I hope that will continue on for the foreseeable future. So thank you very much to you, Len, for communicating with me about Tanya Dorff at the City of Hope and the possible prepping for chemo in advance of that, and to specifically fast for up to 48 hours prior and 24 hours subsequent. Those of you who are Jewish like I am, yes, the one time a year that I used to fast was Yom Kippur, and that was for approximately 24 hours. So pushing it beyond 24 hours, I don't know if I can go more than 24, but I put it open to the brain trust here as to whether it can be beneficial. It seems that it can. I haven't heard of it before, but you know, throwing that out there. So
I don't think you can fast for 36 hours, Carl. You know, I can hardly get through 25, you know? So I think the issue really is you could do an overnight fast. I mean, the people who are talking about fasting and, you know, extending life are actually, there's data that shows like an 18-hour fast every day can do the same thing. So I would suggest that you know, you might want to fast the day of treatment, but don't go crazy the day before or the day after.
So Carl, this is an area I have no expertise in. This is Richard Wassersug here. So, but a couple of things. One is Dorff, who's treating you, has interest in lifestyle stuff, and So I assume you're doing this all with her knowing exactly what you're doing, am I right?
No, she's not the one treating me. It was just that Len had mentioned her in the email to me. I'm on the East Coast. I live in New Jersey. I'm being treated at the Rutgers Cancer Institutes.
Well, are they aware of exactly what you're doing?
Are
they aware of your
well, they're
diet
treating
routine?
me with the chemo. We haven't
No, but I'm talking
discussed.
about the fasting. Are they aware of the fasting? Have
No,
they
no, we
advised you to
haven't
fast?
discussed that. That's a new.
Yeah, well, all right. So in a broad sense, I recommend even when it comes to the supplements or eating everything or eating nothing, you confer with your physician to make sure it's consistent. Because between the carbo and the platinum, that's a pretty heavy hit on the gut. And I have no expertise in this area, but I do think you should be doing it with the knowledge of your treating physician.
Okay, thank you.
I absolutely agree with you. Steve Saft put something in the chat window, so we'll go to him in a second. But Carl, you cut out right at the key moment, so I missed some of what you said before. Have you remeasured your PSA since the 14? Are you still at 14?
Right. The next PSA is going to be in probably about 2 weeks.
And what about your hemoglobin? Has that recovered? Because I think they may have deferred you because of that, right?
It wasn't the hemoglobin, it was the liver enzymes, AST and ALT, and they did tell me to load up on water, and I have been drinking somewhere upwards of 100 ounces of water a day since then.
Okay, are you afloat?
I'm going to the bathroom a lot.
Do we know what's happened to your ALT and AST? Seriously.
I am having blood work tomorrow morning, and it's going to be done on a stat basis. So probably by tomorrow night, if not Wednesday morning, I will have that information.
Do you have another chemo scheduled?
Yes, this Thursday.
Oh, good.
You know, Carl, I would like to just say that, you know, Herb's comment, 48 hours is a long time not to eat. You know, I'd say, I mean, it was pretty normal for me not to eat for a day prior to chemo, but then after chemo, I'd do ice cream. So I would, because that was my treat. I mean, I would hold off on, you know, I'd talk to your doctor really about a 48 hour or anything like that. Because like Richard said, it's a pretty tough treatment, you know, so.
Okay. Thank you, Ken.
Ice cream and dexamethasone, right, Ken?
Mix it together.
I tried fasting the day before, the day of, and half a day afterwards. But then I did a fast mimicking diet called Prolon, which worked well. It's a 5-day fast. It's about 800 to 1,000 calories. I wasn't really hungry. My doctor did know exactly what I was doing. And I also watched that same video by, what's her, Dr. Dorf? Something like that?
Yes.
Tanya. And I think she recommended actually the fast mimicking diet, not to just go on a starvation prison diet.
Okay, thanks.
So it cost, I don't know, $150, $180. Actually, my son's girlfriend got me a discount on them. She works for a health and integrative health medicine company.
Yeah, I did try the Proline diet about 2 years ago, and I wasn't too thrilled with it. It comes in a package with
with 5 days. I mean, I did it for the chemo, not for any other reason. But the 18-hour thing of the intermittent fasting, I've tried that, and when I was eating very healthy and a vegan, that was I did 16 to 18 hours, and I only ate 8 hours a day, and I felt great.
Wow.
All the time. And then I would fast 1 day a week when I did that. I was very fit. I was working out. That was before chemo and before all the other stuff that I've started to deal with.
Yes. Okay, I know we're running late for time and there are other people to talk, so thank you for the input.
And eat, your mother would say. Dr. Wassersug, you're next.
Well, it's nice to be back. For you who do not know who I am a prostate cancer patient. Got so interested in androgen deprivation therapy, the psychological and social impact, that I've ended up writing a book about it called Androgen Deprivation Therapy. And we run here in Canada, where I'm based, in Vancouver, a national program which Americans can take. It's an online class, free for an hour and a half class, plus the book constitutes our educational program. So I'm not pitching the program per se. I'm actually leading up to a request. It turns out that the program is offered, you get the book for free along with the class in Canada. In the United States, you're often waitlisted because we are funded nationally, not internationally, and you don't get the book for free. However, the program, this is the new stuff, rolled out in Europe and is now sponsored there by the European Association of Urology. It's now been activated in the last 2 months in Denmark, central Denmark, Galway, London, and I think the next site they're going to open is near Manchester or Liverpool. And they produced I revised our book, the Androgen Deprivation Therapy book, last summer. So there is a new edition out. But now I get to my appeal. It turns out that our publisher doesn't wish to sell it in North America, which is astonishing. And if you try to buy it in North America, they charge a fortune. And when I went to our publisher and said, what's going on? They said, well, the drug companies, which are our major buyers, haven't complained about the new edition. So why would we want to produce another edition? I mean, major changes. There are a lot of subtle and I think important changes in the new edition. But the spelling of words like behavior has either with an O and a U or only an O. And these type of things matter to the publisher. So if anybody wants the latest version of the book, I invite you, I ask you politely, confidentially, quietly, to complain to the publisher that how come this book is not available in North America, and why, if I have to buy it through Europe, it is so outrageously expensive. So that is one thing I wanted to bring for people's attention. And you can sign up. And by the way, if you're not familiar with it, you're struggling with ADT, or you know someone who's starting on ADT, because that's really where the class is most effective. And simply the website for information is www.lifeonadt is one word.com. So you can learn about the program. And I try to update the literature with a blog entry theirs and so forth. And I'm a little behind because of COVID. Other thing I wanted to bring up was that it turns out one of the reasons I'm here is to see how well you guys are running, and you guys are running really well. Because in Canada now, the support umbrella group, the Prostate Cancer Network of Canada, which is an organization run primarily at provincial level for local support groups, which are largely, of course, under COVID, meeting online, but they would meet in person. And they have decided to run an online advanced prostate cancer support group. And I'm thinking, well, wait a second, one of them already exists. So I've been watching this and looking at the differences between the Canadian and the US situation. And I think the case is that our financial needs are quite different. Our structural concerns are whether one province will fund you for access to a drug, as opposed to whether a drug company will, or an insurance company will cover your coverage. So these issues of access are slightly different. But I wanted to let people know about this, because if anybody's on this call who's Canadian, please contact me. I'll give you the email link, because they're having their first meeting actually on Wednesday. And eventually, perhaps these organizations all need to be working together, because what's going to become clear as a global problem is drugs like actinium-225 are going to be outrageously expensive. And it doesn't matter whether it's your insurance company, your provincial healthcare program, we're going to have a global crisis of access. But that's a political issue, not a supportive issue. But anyway, please contact me if you're Canadian based, and I can fill you in on what they're trying to do up here in Canada. So that's it. I had one, not to pitch my program, but to request that if you want the latest edition of the book, please bitch to my publisher that that's outrageously expensive, and they should make it available in North America. And we're going to have a program. Hopefully, it may be complementary to, and this as effective as your program here, come rolling out in Canada. That's it. Thank you.
Two things, Richard. First of all, if you please put your publisher's name in the chat window so people know who to contact. That would help. Secondly, you said actually three things. Secondly, you said something about the drug companies not objecting to your book. If that's the case, we are more than happy. AnCan is more than happy to speak up for the benefits of your book in any way that we can, and you can reach out to me and we can talk about that.
So the issue was I wrote the book for patients. It never occurred to me that the major buyer would be drug companies in the United States who would buy it to give it to doctors as gifts, which is, by the way, illegal in Canada, who then are happy to get a gift or any gift, put it on the shelf behind them, never read it, never gives to patients. And we're talking about tens of thousands of copies bought by drug companies in the United States for PR purposes. And the publishers love that because it's a massive buy. Not having to fill simple shipping orders to individual patients, and they have not been begged by the drug companies to put out a second edition or a new edition. So this, whether the second edition's out, it would be a third edition in North America. But that to me was outrageous, and that caught me by total surprise after the book was published, that they had no intention of making it available, accessible, or affordable in North America.
I'm going to be in DC next week, and there's going to be a lot of drug reps there. And I'm going to dig into why the heck they haven't asked for another version.
A new edition, knowing that there's a one in Europe.
Okay, I will. And the third thing is we do a fair amount of work with Canadians. I don't think we have any on today, but we often do. We're very sensitive to the differences in accessibility for treatment. And, I wouldn't say we have the expertise that you have, but I think we often give some of the Canadians good ideas and pointers as to where they can find certain treatments in Canada. And we'd love, to the extent we can, we'd love to work with your group, with the Canadian group in any way we can to promote better navigation and support for the Canadians.
I will let them know that. I think you already are in contact with them, but I will let them know for sure. Yes, I seek that global approach. Thank you. And actually, I should sign off now because I have some dinner responsibilities. So thank you all. Bye.
Bye-bye.
Bye, Richard.
I gotta go. Thank you for inviting me, everybody. Nice to meet you all.
So long, James.
Come on back.
Okay.
Julian Morales, you wanted to speak to us?
Just some comments. I've been taking Zytiga, Abby, with Dexa, and I've had a weight gain, probably about 10 pounds in in about a month time frame. Is that normal?
How long have you been taking it?
I've been taking for about 5 months, but it was only recently.
And it's only in the last month that you gain weight?
Yeah, about a month and a half, maybe.
It's hard to say whether it's normal
I don't
or not.
know. I mean, it's one day I was at 195, the next day I was at 210 almost.
One day to the next could
No,
not.
not one day.
That seems.
And it actually fluctuates between 205 and 210, and what fluctuates around 210 plus or minus 5.
When you read the side effects, it is among the side effects they list. Weight gain and appetite changes.
Okay, so that's
Right, but usually it doesn't happen like eat 5 pounds in a day.
No.
Yeah, I think he was exaggerating to make the point.
Yeah.
That happened to me. I had been on dexamethasone. I switched off of prednisone because of insomnia, And also my PSA was rising, and when I switched to dexamethasone, my PSA went level for a few months. But after about, I don't know, like you were saying, probably 7, 8 months, I started weight gain, and I got it super bloated. And as soon as I stopped it, when I started chemo and started taking prednisone, I lost like 5 or 7 pounds, and the bloating went away and everything. So maybe you want to talk to your doc about switching off the dexamethasone and maybe going back on prednisone.
Yeah, I'll see Dr. E next Tuesday. That's one of my conversations I'm planning to have with her.
The other thing that, the other thing, Julian, you know, I never took Abby. I was only on Lucron, but I had big issues with water retention. And so that water retention could have a big impact on my weight even from day to day. I mean, I could be dropping 5 pounds from one day to the next and then putting it back on.
Yes, that's me.
So talk to Jerry about the possibility of water retention. You know, it could have something to do with water retention. Sorry, go ahead, Hub.
No, I agree 100%. That's a very high possibility.
But when they took me off of my blood pressure medication that had a diuretic in it, I really got a lot of water in my system, especially in my knees. And when they put me back on, I went to a lower diuretic, and I seem to be handling all right. I feel some water in my knees every now and then, but that comes and goes, and it's just bothersome, more of a nuisance than anything else. But it's not prolonged, because I do walk every day at least 3 miles.
Good man.
Gotta keep moving. Thank you.
And we will keep moving. Steve Nordstrom, you're next.
Yeah, I have a real quick question. I'm currently on abiraterone and prednisone, and over the weekend I happened to tear my quadricep tendon.
Ouch.
And of course I need surgery, and the doctor really wants me to be off prednisone. So I talked to my medical oncologist, and my question really has to do with tapering. He just said, the medical oncologist said, just cut the dose in half. I'm taking 5 milligrams for about 3 days, and you should be fine. Is that what you guys would agree with?
Yeah, but the question is, are you still taking Abby?
No, he said I shouldn't do that. And he said, you know, I'll only be off for maybe 3 weeks. And he said that shouldn't be a big deal because I'm on Lupron too. So,
I mean, if you're taking 5, if you took 2.5 for a couple of days and then skipped a day and then took 2.5 and then stopped, you'll be fine.
Okay, that's great.
That's what I did when I just stopped recently and tapered myself off of 5 mgs of prednisone using a pill cutter and just.
Yep. All right, that's what I'll do.
That must be a hell of a quad tear to require surgery, Steve.
You know, I live out in Colorado, and you'd think it was from skiing, but I was snow blowing snow, and my foot slipped out, and my knee hyperflexed, and it was.
You could make a better story than that.
I know.
I mean, really, you should have told us that you missed a flag or you were avoiding a tree.
Yeah.
I'm still surprised that you did surgery for it, though. That surprises me.
It was really quite, a lot of torque was into it. I knew right away I was in trouble. So I was on the ground. Anyway.
I mean, we're really sorry to hear this, but we know you'll get back quick. But one quick question. You said you did talk to your doctor. Was that advice that you got tapering off the prednisone from your GU med-onc?
The surgeon wants me to be off prednisone for healing purposes. So I went back and talked to Shmulewicz about tapering.
And that was the advice you got from Shmulewicz to taper.
Yes, absolutely. I mean, he said 5
Okay,
milligrams.
that's what I was checking.
Yeah, he didn't think it was a big deal, so, but he said, yeah, go ahead and taper about 3-4 days.
I
So,
just
and I
want
know
to tell you, there's a very, very well known, I won't name names, but he's exceptionally well known, especially now, G.U. Medonk, who forgot to tell a buddy of mine to taper when he stopped abiraterone, and he lost 30 pounds. And he couldn't figure out what was wrong with him until they realized they never told him to taper.
Wait,
wow.
You taper off of the abiraterone or the prednisone?
Just the
Prednisone.
prednisone.
So he just kept taking prednisone, even though he wasn't taking Abby.
Taking the abiraterone.
No. He stopped his prednisone cold turkey.
Oh.
Carl,
Stopped his prednisone cold turkey, and it can be in some cases it can be quite dangerous, and it screwed up his adrenals, and he was sick for weeks. He couldn't figure out what the heck was wrong with him, and then they finally put 2 and 2 together, and nobody at UCSF had told him to taper off his prednisone.
Wow.
But you guys agree it's 3 to 4 to 5 days of tapering, and then you should be fine, right?
Not me. I'm not giving I'm not talking on this. I'm not
talking
giving
to
medical
I mean,
advice.
we
If
agree with
Shmulewicz said it, it's good enough for me.
We agree with what Shmulewicz said, and I did it.
Right.
Okay, that's what I need.
Feel
Thank
out
you.
of sorts, call him and ask him what does he think and why.
Right. Mm-hmm.
Mm-hmm.
All right, thank you.
Before I get off of this, Ben, I forgot one thing, and I see both of them. I want to just give a real thank you and a big thank you to Herb and Len for this zero program that they moderated.
It was Len, not me.
A very
Len,
good
it's all Len. It's all Len.
No, Herb,
all right.
we were helping out.
Well, I saw you too, and I heard you, so I just want to
Yeah, but
thank
he
you both.
only-
And Rick was back there too.
What does the zero refer to? You're at PSA school?
Cancer.
Oh, okay.
How useful they are.
Oh, we have to edit the tape now.
That's a good question.
I was trying to decide if I could go there.
You remember the part about this call being recorded?
Because you beat me to it.
Herb will be here all week. Good. All right.
Okay.
Say good night. I gotta
Good
go,
night,
guys.
Stephen.
Bye-bye.
Party survivors, Mike Phillips, you've hung in there.
Yeah, I did. I just wanted to update on what's been happening with me. After starting to actively treat my cancer for 6 months, we finally started radiation treatment. I'm early on. I've got four treatments under my belt, 38 to go, 35 to go. And that's the update. I also wanted to say that I had a MRI recently for them to plan this, and I asked for the radiologist's reading of that, and in that interpretation, I found that my prostate has shrunk to half the size it was when I started ADT, and my one lymph node has shrunk by 1/3. So I feel like I can be pretty happy about that.
Yep.
And that's
one of the reasons, Mike, that they give you the ADT for 6 weeks or so before you start, because it gives them a smaller, more concentrated target, and it also theoretically makes the cells weaker and more responsive.
All right. Well, I'm feeling good about things so far, so I'm going to keep going.
Good. And where is your PSA? Has it driven your PSA right down?
It was undetectable in December. And I think at the end of this month, I'm going to have another visit with the doctor, get a Lupron shot, and they'll probably do PSA and testosterone again at that time.
Great.
So that's it for me. Thanks.
Thank you.
Thank you.
Dennis McGuire, thank you for hanging in.
Hey everyone, just a quick update on my lutetium treatments. Had my third lutetium treatment at the University of Chicago last week. My PSA just prior to treatment came down. It's now at 20. So it continues to improve. So that's the update.
How are you feeling?
Feeling okay. You know, a couple days of fatigue after the treatment. That's about it.
So Dennis, I am told that I can just drive myself up to Hopkins, get the treatment, and drive back.
Yeah, I drive myself there. My wife is with me. She drives back. But at the same time, it's 100 miles.
Right, mine is less.
Yeah, short drive. I don't see a problem with that because you have to stay in the treatment room 2 hours after infusion.
Right. And then they say if you're driving with somebody in the car right away, they have to you have to sit in the back seat.
That's the recommendation, yeah.
I like your answer, Mr. McGuire.
I only tell my dog to sit in the back seat.
Right. Well, I have to say, I brought home a Geiger counter, so I'll know what the hell's going on.
Oh boy. You know, we haven't seen your wife in those caregivers meetings for a while. You tell her we miss her. We want to see her again.
You can tell her yourself.
Okay.
No, not your wife.
Oh.
Dennis's wife. Dennis's wife.
I know she joined that one time and I didn't hear afterwards. So I'll talk to her.
You do that. Let me just get this right because the guys should know this. That you started at around 300 and we got you down from there to 150 to 90 and now you're at 20. Is that correct?
That is correct.
Wow.
That's great, Dennis. Keep up the good work.
Yeah, thank you.
Oh
And
man.
how many treatments left?
The plan is to do 3 more.
Every 6 weeks, right?
That's right.
Yeah.
Dennis, how are they taking into account those 3 oddball treatments that you did at Carbone?
I have not discussed that directly with the doctors. I'll know more I'll know more next week. I'm having a update call with the doctor at Chicago just to finalize next treatment.
I forget, are you saying Stadler or Schmulowitz or somebody else?
Patnaik.
Patnaik, right, that's right. Yeah, I've got it right. I've got it down here, yeah. I mean, I just wonder, because again, for the benefit of the people still on the call, Dennis was admitted to a lutetium trial at Carbone, University of Wisconsin, Madison, where they were giving higher doses, but in shorter, but only 3 sessions, and it didn't work that well for you, right?
It worked while I was on the treatment, but 2 months after treatment, my PSA started going up quickly. Yeah. So then after that third treatment at Wisconsin, I was off treatment other than Lupron for 6 months.
Right.
And then I went back on the lutetium in Chicago.
Dennis, I'm so elated for you, man. I'm getting emotional. I'm so happy that this is working. You know, it's great. Boy, fantastic.
Thanks, Rick. Yep. I was getting worried when I was at 300.
Yeah, you weren't the only one. I personally was a little worried too, but I didn't want to tell you, but I was. But you know, we've gotten such a response from 300 to 20 and 3 more to go. I love it. I love it. I love it. And you know, every time I speak to my ladies at Novartis, I make sure to tell them that you're doing great on the Chicago treatment and thank them.
Dennis, it might be time to start talking to your oncologist about a combination therapy with the lutetium, because it does seem that people do eventually develop resistance. And I know I'm pretty sure they're combining it with pembrolizumab and probably other things. So maybe start the conversation about that.
Yeah, I think, Len, my sense is from talking to my guys, this is an expanded access trial. It's a trial.
Yeah.
So the conditions are pretty rigorous. So I think once it gets approved, then I think docs will try to use it with Pembro. But until then, I think you're controlled by the protocol.
Yes, that's true. Yeah. I forgot about the expanded access. There's so many people getting this drug. I was thinking it was approved, but it's not, of course.
Well,
I think what I found out from people at Hopkins who went to Germany, and then they had lutetium, and then when their PSA started to rise again, they just got on another flight to Germany. So evidently, it's something that can be repeated. And Dennis, you would argue that's true.
Yeah.
Yeah, that seems to be the case so far. I guess, Len, the follow-up question I have there is if and when lutetium gets approved, if you go for a combination drug, would you have to do that through a trial?
No. Because a physician can prescribe any drug, even if it's off-label, even if it's not approved for your particular indication. So it wouldn't necessarily have to be in a clinical trial.
Okay.
But the only issue might be insurance.
Right.
Yeah, insurance could be a problem. Of course, it's always better to get into a trial. You get the drugs covered for free.
Does lutetium accumulate in the body, or does it flush out?
Flushes out.
Yeah.
Okay, so it's not like a radiation drug.
Well, radiation drugs flush out too.
Well, yeah, but not all. I mean, some radiation accumulates, and you reach a point where you can't take anymore.
I'm not sure that it's because the radiation accumulates, Peter. I think it's more that your bone marrow can't take it.
Yeah, I mean, the half-life eventually brings the radioactivity down to almost nothing.
Yeah, and that's why the duration is 6 weeks, because with the half-life at that 6-week mark, it's virtually at 0.
Right.
Well, it's the half-life is about 7 days.
Yeah, and I think seven half-lives brings it down to almost nothing.
Right.
5 half-lives are considered 0.
What was that?
5 half-lives are considered 0.
5, okay.
Blimey, there's life on the Eastern Front.
There's some action on the Eastern Front, finally.
Herb, when do you have your first treatment?
A week from Friday, the 18th. So we'll see how it goes.
So, okay to move on. We actually do have moving on that we can do. Some people tuned in late. Don Kramer, George Degnan, Kang. Did any of you want time? Or does anyone want time who has not spoken?
Thanks. I don't need any time. Thanks.
Thank you, Kang. George or Don? Okay, then I think it's a wrap.
Okay.
Great job.
Good job, Ben.
Should we ask him? What do you think, guys? Moderators, we'll ask the moderators first. Should we ask him back to do it again? What do you think, guys?
Absolutely.
Absolutely. And how about the guys out there? Can we have Ben moderate again? Give us a big high sign for that.
Every week.
But Ben, remember to stop the recording.
Yes. Yeah, so I'm glad we got that part on tape. Thank you very much, everybody.
Yeah, Ben.
Yes.
Ben, you're so popular that all of us moderators think you should do it every week.
I second that.
I like the way it keeps it moving without having to push for it. It's like magic.
No, it's great.
The rest of you guys are like, we got to move on. We got to move on. We got to move on. He just moves on. That's it.
Well, it
We
is
knew he was
10:30.
good.
Hey, some of us have been on 4.5 hours now of prostate cancer support calls.
That's
Right. I mean, right. Some of us have been on this.
We're done.
And it's
I'm good with
4.5
this
hours
meeting.
of prostate, and I've been on 4 hours of work today too. So I spent 8.5 hours in front of the machine.
Okay.
I'm gonna go out and take a walk.
Okay. We'll see you all. We've got the
Next
new
week.
guys' names in, and we'll see you all next week and go from there. Good night, everybody.
Good night, everybody.
All right.